So, I'd like to welcome everybody to this first webinar in our series. And today we're going to be talking about food and nutrition in palliative care. To outline what we're going to cover, so I'm going to consider the role of nutrition in palliative care. Think about why is it important to maintain nutrition for our patients. To consider the consequences of malnutrition, the impact of comorbidities, and I'm going to leave you with a case study to think about to see how that might impact on your perception of food and nutrition in the specialist palliative care setting. So I'm going to start off with a definition of the word nutrition. It comes from the Latin word nutrire, meaning to feed and to nourish, and is described in the Oxford English Dictionary as the process of eating or taking nourishment. Now, I think the word nourish is a very interesting word because that isn't necessarily just about the nutritional intake that somebody is having. I think nourish is a much broader word. And is considering the social and emotional aspects around food and nutrition. This will be picked up in later sessions, particularly the session around cachexia, where we will consider the social and emotional aspects of eating and drinking, which is something that I think is very, very important in a palliative care setting, in all settings, but particularly when somebody is in the final stages of their life. Just going to another definition, I think it's important that we think about what is palliative care. And you will see there the WHO definition of palliative care as being an approach that improves quality of life of patients and their families facing problems associated with life-threatening illness through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial and spiritual. And again, I think food and nutrition fits so much within this definition. Eating and drinking is all about quality of life. And how people eat and drink and how they manage on a day-to-day basis has a strong relationship with how they feel about their day-to-day life and how their families feel. We will talk about identifying malnutrition and assessing for it in a later webinar again, but you will see that early identification and assessment is key to what we do in palliative care. And then it is really important that we think about pain. Pain is often the most profound symptom that people will experience, but symptoms associated with somebody's ability to eat and drink can have major psychosocial impact. So I think it is absolutely right to think about eating and drinking within the palliative care setting. And then think about the role of healthcare professionals in nutrition. So Eldridge and Power define the role to identify and address nutritional factors that impair a patient's physical and psychological well-being, with the primary objective of being to maintain or improve quality of life for the individual. So again, that key element about quality of life. We might not be able to help somebody to gain lots of weight, to regain lots of weight that they have lost, but what we might be able to do is support somebody and their family so that they can have as good a quality of life and achieve the things that they want to do in the last stages of their life. So what is the role of nutrition in palliative care? Well, on a basic level, it is the provision of nutrients. So although I have just said how important the psychosocial impact is, obviously the provision of nutrients in the form of energy, protein, vitamins and minerals is what we are doing when we are thinking about nutrition. what we should be aiming to do is to prevent or treat avoidable malnutrition by a method that is acceptable to the patient. Now, in some cases, it is difficult to avoid malnutrition. We will talk about cachexia later on in the series, but cachexia, especially at the end stage of cachexia, is not reversible. It isn't possible to reverse malnutrition by normal means. So we might not be treating, as in preventing it completely from happening, but it's about thinking about what is going on and how can we support that patient and their family to cope with this malnutrition. Eating and drinking can help to maintain a sense of normality. And if we think about our day-to-day lives, our days are punctuated by eating and drinking. You eat at your meal times. Many of you are probably like me. 12:30 comes around, you start thinking it's lunchtime. When I'm going up on the wards, I can see how for the patients a lot of the day is revolving around the times when they are eating and drinking, because they're such an important part of our life. And even if you can only eat small amounts, to still have those times when you are doing what you would normally do. You're having a little breakfast, you're having a bowl of soup at lunchtime. It helps to maintain that sense of normality in people's lives. And when people are not eating, that can evoke feelings of despair. And I'm sure that you will have seen that in patients, but also in family members and friends, to see your loved one unable to eat or eating very, very tiny amounts is highly distressing. I think it sets up all kinds of thoughts about what is happening to that person, and it's about their deterioration and the fact that maybe that person is not going to get well from this illness. When you think about being ill with a condition that can be treated, one of the signs that you are getting better is that you are up and about and starting to eat and drink again. And that is something that can be very challenging for our group of patients. And as I say, I will explore this further in a later webinar. So let's think about the kind of things that affect people's nutritional intake. I've popped up the Eat Well guide there. Because I think it is important to acknowledge what normal eating and drinking would look like. And we will hear a lot about healthy eating and what people should be eating and drinking on a day-to-day basis. And the Eat Well guide gives us an outline for that. So I will let you have a look at that resource. I think that that's quite self-explanatory. It goes through the different food groups and identifies the proportions of the daily intake that people should be aiming for. Those resources are available quite easily online. So if you Google Eat Well Guide, then you will find that diagram and also some accompanying notes that go with the Eat Well Guide. So what kind of factors will be affecting our patients' food intake? And I've divided them up into the physical factors and the psychological factors. So thinking about physical factors first. A lot of things that people experience during illness will affect their ability to eat. So for example, constipation can have a major impact on people. People say to me they feel bunged up as far as they can go and they just don't feel as if they can put anything else into their gut because of the way that that constipation makes them feel. Malabsorption is when people might have very profuse diarrhea, for example, and they're losing a lot of the fluid and the nutrients that they are eating. So malabsorption can be quite a problem. You might see fatty malabsorption where people's stools are very, very light coloured and fatty, indicating that they're not absorbing fat properly, and fat is quite an important factor for keeping the weight steady. Mucositis, which is when the mouth can be really, really sore. You will often see that after people have had treatments for head and neck cancer. And if you think about if you have something like a mouth ulcer, how painful that can be. If you then replicate that across the whole mouth, we can really empathise with how people find it very difficult to eat when they do have mucositis. Nausea and vomiting are obviously major problems for people. It is impossible to eat if you feel that anything that you put into your mouth is going to make you feel sick or that you are going to vomit. It's very, very difficult to help people get through those symptoms. People may have obstructions anywhere along the GI tract. So you might have an esophageal obstruction in esophageal cancer, or if you've got tumours pressing in on the esophagus, and further down into the GI tract. So we often see people who've had pelvic radiation, for example, might get a lot of adhesions in their bowel that might result in obstruction of the bowel. That might be acute and it resolves, or it might become an ongoing problem for people. So being obstructed along your GI tract is obviously going to affect what you can put in and what comes out. And people may also have dysphagia, which is the diagnosed swallowing difficulty associated with their illness, particularly, say, for people with neurological conditions. A range of oral problems, such as thrush and dry mouth, sore mouth, will all affect what people can eat and drink. And obviously pain itself. Pain, as we know, is all-encompassing. And when people are in a lot of physical pain, it can be very difficult for them to eat and drink. And the psychological factors that will affect people's eating and drinking include anxiety and depression, inability to sleep, spiritual distress, and family worries. If you think about the person lying in bed or sitting in their house for long periods of time, there might be lots of anxiety and depression and worry going on, and those kind of things really can impact on people's food intake. And if you think about Dame Cicely Saunders' description of total pain, so we talk about pain, the physical pain, but actually total pain takes into account the spiritual distress. And again, we can define spiritual in different ways, but existential distress, all of those things that can affect how people feel about what is happening to them. So both physical and psychological factors can have a major impact on what people are able to eat and drink. And then thinking about what's important to patients. Oh, sorry, just a little further description there of things that affect people's nutritional intake. And I think the only one just to add is obviously in the terminal phase of the illness, as somebody is dying, there will be a decline in gastric emptying, there will be a decline in digestion, absorption and peristalsis, so those autonomic movements that happen through the gut to help people digest. Those processes do decline as somebody is dying. And that is why, when people are dying, they don't feel hungry. That's one of the reasons why people don't feel hungry and don't want to eat and drink, which is very difficult for those around them to see. But I think it is important just to remember that it is a natural part of the dying process. And I think sometimes we have to be very clear when we talk to family members about that. So thinking about what's important to patients, I think quality of life is the most important thing for many people. They want to be able to do the things that they want to manage. So maintaining physical strength to undertake final wishes and ambitions can be really, really important to people. Ongoing treatment is often important. So people might be having palliative chemotherapy, they might be weighed, they might have been told that if they lose too much weight, they might not be able to have so much treatment, so that might affect their outcome. So that can be a very important factor. Having the physical strength to benefit from rehabilitative palliative care is often very important. We'll talk about that in the next slide. And as I've already mentioned, the social and emotional meaning of eating and drinking is often very profound for patients and for their families. I just want to touch on rehabilitative palliative care. This document was published by Hospice UK probably about 18 months ago now, 2015. And I think the subtitle, underlying people to live fully until they die, is really, really important for us to remember, because that is what we're trying to help people to do. When we're thinking about rehabilitation, it's not necessarily about getting somebody back to their previous function, because we are considering it in the context of a deteriorating, declining illness. But within the context of that illness, people still say that they want to be able to do as much as they can, and I think nutrition is a very key part of that. So we need to think about nutrition as early as possible to enable patients to get the maximum benefit. Dietitians do play a fundamental role in this. I would say that, I'm a dietitian, but I think we do have the knowledge and skills and expertise to really support people to benefit from their rehabilitative palliative care. However, I do acknowledge that for many places you don't have your own dietitian, and we will think in later webinars about what general principles you can put in place to support your patients with their nutrition. And if we're thinking about holistic care, nutrition to me is a core part of that holistic care. From the nutrition, the actual nutrients it brings, but from the social and emotional impact as well. So there's a definition there of what actually is malnutrition. So it's a deficiency or an excess or an imbalance that we've talked about. And I think it's important to remember that malnutrition refers to undernutrition, where people aren't having sufficient nutrients, which is what we will see predominantly. But it also does refer to overnutrition, where people are having more nutrients than they need. And if we think that our society is becoming increasingly obese, we will see more patients in our hospices and nursing homes who are obese. But just because they are overweight doesn't necessarily mean that they're not malnourished. So I think we have to think very carefully about actually what's happened with that person in general. They might be 100 kilos now, so they might look overweight, but actually they've lost 20 kilos in the past 3 months unintentionally. So I would say that person is malnourished, and that there are things that we need to do to consider that. So thinking of some consequences of malnutrition, so I've just listed them there: impaired immune function, delayed wound healing, muscle wasting, weakness, which can affect all the systems of the body, the respiratory muscles, cardiac function, and obviously mobility. It can cause altered GI structure and function, and often will cause apathy and depression in people. And that can be quite hard to reverse. And I will often see patients who are very low in mood, and their eating and drinking is sorely affected. And it becomes a bit of a vicious circle, because the less they're able to eat, the worse they feel about it and become more depressed. So actually breaking that cycle can be quite a challenge. So I just want to put up this case study, and when you're watching this, or if you're in groups, have a think about what you would do in this case. So Mrs. B is 53, she's got metastatic bowel cancer. She had an ileostomy formed 4 months ago and is currently having fortnightly chemotherapy. She's losing weight, and she says that her appetite is really small. So what kind of advice would you give to that patient? From my point of view, I would be talking to her to find out about how much weight she's lost, what kind of food she is able to eat. So the fact that her appetite is small, how is that different to how she used to eat? And what kind of advice might I give her to support that? So I might be saying to try to eat small amounts more frequently throughout the day. So you'll often hear about small or often, or people saying they can only eat snacks. Nothing wrong with being only able to eat snacks. I think having small amounts but spread out a little bit more can be a really, really positive strategy for people. If this patient's, she's still having chemotherapy, it might be palliative chemotherapy, it will be because we're in a palliative setting, but she will be quite conscious of her weight because she will be weighed for that chemo. So we will have to talk about what's happened to her weight, what she thinks is important. I might talk a little bit about preventing too much weight loss rather than actually gaining her weight, because it might be quite difficult for her to regain the weight. We might need to talk about how she's managing the side effects of her chemotherapy, nausea, vomiting, fatigue, which can all impact on eating and drinking. And we would also talk about the ileostomy and how she's managing with the ileostomy. Some people manage really well, really quickly. Other people struggle. She's got an ileostomy, so the output might be quite high. So we'd look at some practical ways of helping to manage high output, or the kinds of foods that she can eat. I often see people who are really, really frightened to eat because they've been told that different foods, different types of foods might block their ileostomy. And that just makes people so paranoid that they really find it difficult to eat anything. So we'd explore that and work out what might be right for her. But maybe in your groups or in your setting, have a think about what you would do with that kind of patient. I wanted to just talk a little bit about the nutritional impact of comorbidities, because we will see people are living longer with their disease, but in palliative care we will see people who have renal disease, who have diabetes, who might have had heart disease, for example. So people here might have been living with, say, their diabetes for 20, 30 years. They might have a particular way of eating because of their diabetes. They might want to avoid very high sugar foods, or they may have always avoided very high sugar foods, but now they're not eating very much. The only thing they really fancy is a bit of soup and maybe a bowl of custard after their meal. And people will often say to me, oh, all I fancy is a bit of cake or a bit of custard, but I know I shouldn't be having that because of my diabetes. And I think we have to work really carefully with the patient and as a multidisciplinary team to work out what are the priorities for that patient. When we're thinking about diabetes, when we're managing diabetes as a long-term condition, we want to try and avoid the long-term implications, macrovascular disease, microvascular disease. Realistically, if people have a life-limiting condition, and they may be in the last 6 months or 1 year of their life, avoiding heart disease might not anymore be the main priority. So we need to think very carefully about how we present that to the patient and how we slightly change what the priorities are. And it's very much about listening to the patient and what's important for them. But what I will often talk to people about is that it's about avoiding symptoms maybe due to very high blood sugar levels. So some of the symptoms of hyperglycemia will be things like feeling very thirsty, going to the toilet very frequently, feeling very fatigued because your blood sugar levels are high and you're not utilising the sugar properly. So we would be looking at, right, have you got any of those symptoms? How might we help reduce the impact of those symptoms? And actually, I will often be talking with the patient and with the medical team about letting the patient eat whatever it is they want to eat, because if they're only eating small amounts, that's probably not going to have a major impact on their blood sugar. And actually looking at the pharmacological treatment of their diabetes. So it may be that person's on steroids, and that's what's really tipped their blood sugar levels over into hyperglycemia. So we might be looking at their diabetic medication. Do they need a little bit more of their normal tablets? Do they need some short-acting insulin to help at meal times, just to get those blood sugar levels back down to a reasonable level so that they're not symptomatic of having hyperglycemia? The emphasis is kind of moved away from avoiding the long-term impact, because realistically, the person is not, their cause of death is not necessarily going to be about heart disease. It might be their cancer that will actually result in their death. So it's about balancing out those priorities. And that can be quite hard to do with patients and with their families. So I think careful discussions need to be had within the multidisciplinary team. I've put up another case study there for you to consider. And you can kind of consider that in the context of what I've just spoken about, really, about what are the priorities for this person, and what do you think you would do in this situation. Okay. So there's some references there for you. I think what I'd like to say at this point is that while I think that the role of the dietitian is really, really important in palliative care settings, I know that in reality, not everybody has access to a dietitian on site or even over the phone or through community links. So the purpose really of the following webinars is to help you think about your own particular area, what you can do as nurses, healthcare assistants, catering staff, doctors, help you to think about some practical ways of addressing difficulties with eating and drinking within your particular establishment, your nursing home, your hospice. And we will explore a little bit further the psychosocial impact of eating and drinking. So I hope that you found that useful, and I look forward to seeing you at the next webinar.